Next topic is interpretation of MRI in rectal cancer. And the presenter is Dr. Satish Babu, Consultant Onco and Interventional Radiologist, Sulekha Yenapoya, Institute of Oncology, Mangaluru.
So my topic is on interpretation. So you will be, by the end of this section, those who are sitting in this hall should be able to interpret basic MRI. So I will not be going into the radiological jargons and all, so it will be very simple. So as you know, MRI was validated as an investigation of choice or investigative tool following the Mercury trial. So there is Mercury trial 1 and Mercury trial 2. One is for the upper and mid, and 2 is for the lower rectum and anal canal. Okay, so how to start? So you have to remember that it's not just interpreting the MRI that's important. It's important that you take it properly. So you should not give everything to the technologist. Contrast study is not needed because it doesn't add to any value. Upper abdomen screening is important. So endorectal MRI and UST is used in selected cases where you want to know about whether it is a T1 or T2 stage. So protocol, you need a high-end MRI, at least 1.5 Tesla or 3 Tesla. External coil is needed. It's called external surface array coils. Preparation is usually not needed, but if it's constipated, you can give a preparation. Endorectal fluid or nothing should be given. Filling should not be given. And endorectal coils are usually not used now because previously it were used because it gives better resolution. But now the surface coil is equally good. So the first phase is take a SAG T2. So SAG T2 is the first sequence you should be doing, and based on that you have to plan the axial and coronal. So axial should be perpendicular to the lesion and not perpendicular to the pelvis, and coronal should be parallel to the lesion. Now if the lesion is in the lower rectum, you have to take along the anal canal. The coronal should be along the anal canal so that you know the relation of the tumor with the sphincter. So what's the importance of this planning is, you can see in the red line, that red line is actually just axial. So when in the second diagram you can see that tumor is abutting the prostate and involving the mesorectal fascia. But actually when you look, if you had taken perpendicular to the tumor, that yellow line, you can see there is a fat between the lesion and the prostate. So there is no involvement of the mesorectal fascia. So that's the importance of planning. But you can still find out that from the SAG that there is still a fat plane, so there is no involvement of the mesorectal fascia. Now you have to know where is the rectum and extent of the rectum, because in SAG, even if you look, because of the tumor there may be contraction of the length of the rectum. So we take the sigmoid rectosigmoid junction from the what is known as sigmoid takeoff sign. So and the distal end, that is a anorectal angle, is taken from the lower end of the pubic symphysis by a line drawn from the lower end of the pubic symphysis to the sacrum. So that is taken as the lower end of the lower rectum. So what I was telling is a sigmoid takeoff sign. So you know the rectum comes parallel to the sacrum. So at one stage it goes perpendicular to the rectum. That is called sigmoid takeoff sign. So from there rectosigmoid junction starts, and it has found in studies that it is reasonably good in predicting the rectosigmoid junction. And another point you have to know before interpreting the MRI is the peritoneal reflection. Actually, you can nicely see the peritoneal reflections in MRI. So, as you know, the higher rectum is covered by the peritoneum in the anterior lateral part and mid rectum in the anterior part, whereas lower rectum is completely covered by the mesorectal fascia and there is no peritoneal reflection there. So, based on the SAG T2, you have planned axial T2 and coronal T2. So the workhorse of MR rectum is T2 sequence. That's the only sequence as a clinician you need to see. Additional sequence we take is a diffusion weighted imaging for rolling out following up during the post chemotherapy MRI. Then T1 sequence to rule out marrow infiltration of marrow deposits. Just like T2 is the workhorse for rectum imaging, the T1 sequence is the workhorse for marrow infiltration. So T1 sequence is very important to rule out marrow involvement. IV contrast not needed. Fat suppressed T2 is occasionally taken, especially when there is additional, like if there is a perianal fistula or abscess, sometimes this tumor can cause secondary infections of the anal gland and abscesses. And another condition is where there is a mucinous tumor of the colon or rectum. This fat, as you know, is white in T2, and mucinous tumor will be also be white in T2. So you will not be able to differentiate between the tumor and the fat. So in such cases, the fat suppressed sequence will help. And abdominal screening is routinely taken because sometimes what happens, even though we take metastatic workup, PET CT or CT, small liver lesions can be missed. So those lesions can be picked up in MR screening of the liver. So we start. So this is the first sequence you have to look at. So this is a SAG T2 sequence. You can see how you look at the bladder. There is a fluid which is white. So that's the easy way for a clinician to say that this is a T2. Okay. So as you scroll down, you can see this is the tumor. So in this SAG sequence, you should be seeing the whatever we look at extent of the tumor, length. We will measure the length of the tumor, surrounding structures we see, and lower end of the tumor from the anorectal angle. So you distance, what is the distance from there, and what is the area is involved, whether it's a mid rectum. In this you feel that it's upper rectum, no, mid rectum is involved. Actually it is involving the rectosigmoid junction and mid rectum. How you know? You have to look at the sigmoid takeoff sign that you better appreciate in the axial section. So you can see that. You can look at the extent of the tumor, and in SAG, one more thing you have to see. You have to see the peritoneal reflections. So in the peritoneal, if you see it there, actually you can see if you look at this is the peritoneal reflections, small black line. So that's so you can see it's coming like this and it's going anteriorly. So that's a peritoneal reflection. So if you scroll it down, you can nicely see the peritoneum. So this is the axial section. So so if you scroll it down, so you can see this is a rectum which is going parallel to, but if you go back, at one time it just shoots out perpendicular. So that's a sigmoid area, so rectosigmoid junction. So there's a tumor there. So actually it's involving the rectosigmoid junction. Going down, it's involving the rectum, and you can see small. So you can see the small lines there. So it is not tumor, actually it is a desmoplastic reaction. So how will you differentiate between desmoplastic reaction and tumor infiltration? Desmoplastic reaction will be very thin black line, whereas tumor infiltration will be little gray. So here it is actually a T2 bar T3A. Because some area there is a small infiltration, which is, you can see that gray area. So that's a T3A. So it can be treated as a direct surgery, TME. You can directly go for TME. Whereas, so these black lines actually, if you go back, these black lines are not infiltration, it's actually desmoplastic reaction. So and in the coronal is the important sequence when you want to know the relation between, this is the sphincter, you can see the levator, puborectalis and external sphincter, and you can see the fat in the sphincteric plane, the fat plane. So here you can see the tumor is well above the levator, and that fat and all are maintained. So this is how, when there's a lower rectum, you have to look at this area very carefully to rule out involvement of the intersphincteric plane and the muscle. Because if muscle involvement, that is levator ani, puborectalis or the external sphincter is what, it is taken as T4B. Whereas if up to intersphincteric plane, it is not considered in the TNM stage. It is only important for a surgical plane. So this is a tumor which we have seen previously. So this is another case. You can see tumor, and you can see the infiltration into the perirectal fat. You can see the gray thing. So it's not a white line; it's a thick gray line. And you can look at the relation with this mesorectal fascia, and it's very close to that. This is involved. So the distance of the tumor node or any infiltration or even EMBI, 1 mm or less than 1 mm towards the mesorectal fascia is taken as infiltration of the mesorectal fascia. So 1 mm or less than 1 mm is taken as infiltration, either it's a tumor, node, or whatever it is. And you have to look at this is a fascia, so there's a node outside this fascia, so that's an extra mesorectal node. So there are criteria to define the node that will come later. So you can see the tumor, it's a very extensive tumor. As you go down, it is going into the lower rectum, close to the sphincter, and as you come down, you can see it is involved, it is very close to the sphincter. So in these cases, you have to look in the coronal for the involvement of the sphincter. So this is a criteria which I told. So 3 criteria are used: irregular margin, heterogeneous signal intensity, and round shape. If all the 3 are there, even if it is less than 5 mm, it is taken as positive. Only 2 features are there, so size should be between 5 and 9, and none of the feature is there. But if it's more than 9 mm, it is taken as positive node. So this case, as you go, this is the same case. So we have to look at the sphincter. So you can see that fat here is gone from here. So there is infiltration of the fat, and it is abutting the sphincter. And as you go down, you can see there is a local infiltration of the sphincter. So that's the importance of looking in the coronal. Okay. So this is another case. So you can see here something is going very in a serpiginous manner, which is not a straight thing. So that's actually the tumor infiltration into the vein, which is known as extramural venous invasion. So when the tumor is going into the fat, it will be straight. When it is in a serpiginous manner, you have to suspect EMBI, which is a prognostic factor. So, and what else you see? There is a so this is a EMBI. So this is a here you can see multiple so multiple white lesions like that, usually should be gray. So these are mucinous nodes, so which are better seen in, you can see the tumor itself is white, so there is a mucin within the tumor. So which are better seen in fat suppressor sequence. So you can see all these nodes which are white, whereas fat is suppressed in fat sequence. So this is one area where T2 fat suppression is useful. So this was the one which I was telling, the criteria for the nodes, especially the lateral nodes, more than 7 mm. So only the size criteria used for this lateral nodes. And some of the controversies in this TNM staging, like whether it is like obturator nodes, whether it's internal iliac nodes, were defined in this paper. Like if you draw a line lateral to the lateral wall of the internal iliac artery, anything coming lateral is taken as obturator node, and medial is taken as an internal iliac node. And based on all these findings, this is a synoptic reporting format. So we have to use this format so that we don't miss anything, and clinicians get all the details needed for surgery. And restaging is also based on the MRI, and we use something called tumor regression grade, which to parallel the tumor regression grade used by the pathologist. There's a trial going on to develop a patient management algorithm based on tumor regression grading. So this is a 5-point tumor regression grading which we use. Last slide. So in this you can say this is a large tumor there before treatment, and this is a last tumor treatment after the treatment. MRI after the treatment, you can see the scar, only black line, so there's a fibrous scar. And this is another case where there is still a tumor, and after treatment you can see there is still small tumor there. So we use the diffusion in these cases, so where you can see the white thing here, and the ADC, you can see the black ADC. So there is a diffusion restriction. So it is a little difficult for a non-clinician, non-radiologist. So based on the MRI, there is some diffusion we can use modified 3-point MR tumor regression grading, which is not standardized, but still we as a radiologist use this, but very useful. And based on that, we stage and response as near complete, intermediate or poor response. MRF, even if there is even if a scar is there less than 1 mm is taken as positive, because more than 50% is usually positive, and any node more than 5 mm is taken as positive. Thank you.
So good morning to all of you, and I would like to thanks to organizers and Vijay Kumar sir to give opportunity to present my thoughts on the HIPEC in colon cancer. So first of things, I want to discuss that peritoneal metastasis in colon cancer is quite low in incidence, and isolated identification of isolated metastasis is very low regarding to associated with other metastatic regions. So approximately 4 to 15% of patients are diagnosed at the time of diagnosis colorectal cancer present with the isolated peritoneal metastasis. And during the process, after the treatment, the chances of 25% of patients had recurrence in peritoneum isolated disease over the period at the time of recurrence. So if I discuss the survival with peritoneal metastasis in colon cancer and colorectal cancer, the data is slightly limited, and the data is mixed with the stage 4A and 4B. And usually associated with the other sites also. So, and tumor burden is diagnosed patient is very low at the time of diagnosis. So selection criteria for treatment type and sequence of the treatment in patient with CRC with isolated disease very ill defined. So if I see about that, the patient with colorectal cancer with metastatic disease, the palliative systemic treatment is the standard guideline treatment there, with a survival with median approximately 13 to 16 months. And usually the isolated disease is not detected earlier. So under our topic is the HIPEC in colorectal cancers with metastatic disease. So in two settings is when use, one is adjuvant setting and one is prophylactic setting. Adjuvant setting means the patient has had the peritoneal metastatic disease there, and we are giving CRS followed by HIPEC either simultaneous or later on. Another prophylactic patients, those patients high risk for the development of peritoneal disease later on. So these patients can be used for CRS or standard radical surgery with HIPEC surgery. So if I discuss about the data, the recent last 20-25 years, two reports are there. One report is there around 100 patients and one is 50 patients due to poor accrual selection of patient. So they have found that with comparison with palliative only chemotherapy, no surgery, no HIPEC, the comparison with the CRS with HIPEC, either HIPEC or intravenous chemotherapy, they found that disease-free survival is increasing with the HIPEC and CRS in comparison to only chemotherapy patients. So around the 22 months comparison 12 months in one study, and second in 5-year overall survival also is 33% with CRS only. These studies are inclusion of the chemotherapy regime, mitomycin based, and they used in the only metastatic CRC. There is significant improvement, either local reports and systemic, and the other overall survival also. And earlier for profile, some phase 3 study also reported that is oxaliplatin based, but they didn't show any survival advantage with the HIPEC comparison with only standard radical surgery or cytoreductive completion surgery. Only few patients, those who have limited peritoneal PCI, approximately 11 to 15, that subset of patients had advantage of overall survival, that is significantly approximately 10 months with the HIPEC. This study is reported with the retrospective analysis, those patients with the fit for the propensity scoring. That means the patient is best suitable, they have found that best suitable patient for HIPEC surgery, and those included only T4 and N0, N1 patients, and they have compared the two groups in the one is surgery with HIPEC surgery. So they found that the 3 years peritoneal metastasis free patients had the 11.1% versus 2.2. It means that significantly local control will be there if patient will be selection only T4 and N0, N1 disease there. And disease-free survival also slightly higher with the HIPEC surgery. And few patients, maximum the patients are included with the laparoscopic surgery also. So, but they have found that it is safe and feasible with affordable complication and good survival. So adjuvant HIPEC also is studied various reports. They have found that peritoneal metastasis free survival is better with HIPEC group in the patient. And another advantage is that subclinical peritoneal metastasis is very difficult to diagnose with the conventional imaging also. So if patient undergo the HIPEC surgery subsequently, that is second look surgery, that is the detection of subclinical metastasis is higher, so better result will be there. So these are the three trials for prophylactic HIPEC. The one is prophylactic. They have included high-risk patient, ovarian metastasis, perforated tumor. They have used a 6-month adjuvant treatment followed by either surveillance or second look surgery with HIPEC. They decided a primary endpoint with 3-year disease-free survival. They did not meet the standard up to the level advantage, and because in this report they have found, although they have found the macroscopic disease during second look surgery, 50% occult short-term interval recurrence chances there, because they have given gap of the 6 to 8 weeks. And this study shows that conventional imaging has low in sensitivity to diagnose the peritoneal metastasis, those who are occurring during the gap period of surgery and adjuvant chemotherapy. That's why this report, although is supporting the prophylactic treatment in these subset of patients, HIPEC is required, but not with up to the resulting the disease-free survival. The drawback is that the oxaliplatin-based chemotherapy was there. Neoadjuvant also patient received oxaliplatin. There might be chance of chemo resistance, and they have used short perfusion time. And in these HIPEC patients, they delayed the adjuvant treatment also. Second is the Colopec. They also, some patients locally advanced is perforated. They included T4, N0, N2 also they included. And they also found, did not up to the, they found that the survival advantage in both the groups. And in these studies, the drawback was that they have used the second look surgery laparoscopically, maximum patient around 90%. So there might be chances of the most of the patients, 70% had the adhesions. They reduced the exposure area, and delayed systemic chemo also was there. So at the time of second look surgery, only 10% had patient peritoneal metastasis was occurred. Third is HIPEC. HIPEC is they decided to patient locally advanced colon cancer, CRS versus concurrent CRS with HIPEC. They have used HIPEC in simultaneously single operation and same sitting, and they used a differently drug is the mitomycin C, and they decided to primary endpoint will be local treatment. The HIPEC only affect the local results, not the systemic properly. So they have decided to a primary endpoint will be the local recurrence. So they achieved the optimum results with this trial. Only the peritoneal free metastasis has very chances. So, and this study is the advantage that the strongest point of the homogeneous selection was there. Only T4, N0, N1. Primary endpoint was directly correlated with HIPEC, and they use different drug. Duration is optimum 60 minutes, and they use simultaneously. There the chances of less chances of delayed systemic chemotherapy. So based on these adjuvant and reports, adjuvant and prophylactic HIPEC can be used to treat the peritoneal metastasis selected patients only at high volume centers, not to prevent. So basic reason between the shifting of the oxaliplatin to mitomycin, maximum reports are showed that they have the failure to achieve the optimum results. So it might be because of the chemo resistance that is found on the studies, that those patients have received neoadjuvant chemotherapy based on oxaliplatin. They have resistance of more than 60% compared to only 33% they did not have. Few ongoing RCTs are there comparing the mitomycin C, and the maximum RCTs are using the simultaneous or immediate or short interval between surgery and HIPEC. And they are maximum trials are using the primary endpoint directly peritoneal metastasis free survival only. So might be result will be better in these trials. Let me see. I want to discuss some SOGI consensus last 2022 how decided. They have these consensus based on the panelist and evidence-based recommendation, few opinion-based, and few research priorities that decided. Evidence-based, they found that high dose oxaliplatin is results to high complication rate but no survival benefit. If you compare that oxaliplatin versus mitomycin C have low complication, better local control, but no survival in the form of survival advantage. Duration is favorable to the longer duration, optimum is 60 minutes, later on the 90 minutes if possible. And they also found that evidence-based in research reports, retrospective observational studies, they found that repeat CRS and HIPEC also in isolated pediatric metastasis is feasible to do to increase the survival. One consensus based on the opinions, based on the specialist, the panelist, they have found that a HIPEC after primary CRS is better to rather than to HIPEC followed by after the CRS and after a gap period. And patients, those who have recurrence in pediatric metastasis within 1 year, they are not advised for redo HIPEC. But after the 1 year, if the gap is more than 12 months, then better to go for redo CRS and HIPEC in selected patients. And the best protocol is that mitomycin-based protocol. And they have decided to some research priority also that those who have patient already metastasized with peritoneal limited disease, they have research promoted that they have should patient go for CRS with HIPEC plus CRS, and that drug should be dependent on neoadjuvant protocols, and the longer duration can be assessed and multiple drug can be used, so that should be assessed in further studies. One report is recently published, meta-analysis based on the peritoneal recurrences after either standard surgery or previous CRS with or without HIPEC. So repeated CRS and HIPEC is feasible and in selected patients. Second look observed that the chances of the identification of pediatric metastasis in the earlier stage, and they have also found that those who patient received the redo surgery and with HIPEC, they found the median overall survival is 42 versus 11 months is the record. So few factors are affecting the HIPEC in the colorectal cancer, mainly duration of application. Best duration is 60 minutes rather than to short duration 30 minutes. Temperature should be optimum around the 42, 41. And cycle of treatments, if some reports are also studied that multiple cycle will be better, but needs not confirmatory. Drug dose and carrier is already discussed. PCI is the limited PCI, approximately the less than 15%. 15 PCI is the best outcome with this HIPEC. And some peritoneal surface disease severity score also is a stage 1 and 2 is better option for HIPEC, CRS with HIPEC rather than to stage group 3 and 4. And CC score, they found that CC0 and CC1 is best outcome with the HIPEC rather than to CC2. And systemic treatment always optimum at the should be on the time and not be, should be delayed. So if delay is there, then will be negative for the survival. So my conclusion is the metastatic colorectal cancer colon systemic treatment is still gold standard, and it is very difficult to classify the HIPEC procedure for colonic metastasis to peritoneal surface in therapeutic approach. Very difficult to classify. So NCCN also stated that possible curative option in selected patients, and a few patients with T4, N1, N0, N1 or PS good, PCI limited, and good patient selection, we can go for HIPEC at higher centers, and his experience should be high. So thank you.
Thank you, sir, for sharing your knowledge with us. Any question from the audience?
Any questions from the audience? If not, just I want to know one thing. You kept on mentioning about second look surgery. Do they follow that at this point of time? You mentioned about second look. In your adjuvant setting also you were mentioning about second look. And the last previous slide also you mentioned about second look. Because at this point of time with the radiological investigation and other things, we don't go for a second look laparoscopy. Do you believe in that second look?
No, actually some studies have shown that if you do for second look laparoscopy, so they have found early peritoneal metastasis. So those patients are limited peritoneal metastasis recurrence, so better result with high CRS, second redo CRS with HIPEC. Only few subset of patients.
Thank you. Nice. Thank you.
Rani, Professor Colorectal and Robotic Surgery, Tata Memorial Center, Mumbai, to give his surgical perspective.
Hello, good morning everyone. Great to be here. I'm Saklani. Thanks to Navina and Shirley. So I think the topic today is early rectal cancer. So I am not an expert in early rectal cancer. I think only 3% of the patients have early rectal cancer in the country so far. Most of them are locally advanced, but the talk is on it, and it is really challenging, and things are changing now. So when you talk about early rectal cancers, you're mainly talking about T1 or T2 rectal cancers. The T1 would be seeing the submucosa, and T2 would involve the muscle. So why is it important? Because the management is different. So how do you differentiate whether it is T2 or T3? So you normally use MRI for staging, so which is very good to differentiate between T2 and T3. But to differentiate between T1 and T2, you need an endoscopic ultrasound. And that will decide, because if it's a T2 tumor, you will probably require TME as a standard approach, or TM1, you can do local excision. And the reason for this is the incidence of lymph node mets. So if it's a T1 rectal cancer, SM1 or SM2, incidence of lymph node mets is less than 5%. So you can do a local excision, then that will be the only one. But if you have any high risk factors, lymphovascular invasion, poor differentiation, then the lymph node metastasis is high. For T2 rectal cancers, the incidence of lymph node mets is more than 20%. And if you have any adverse feature, then the incidence of lymph node metastasis is really high. And I'll just show you a video if it works. So now, suppose if you've done an MRI and you find out it's a T1 or T2 cancer, you do an EOS and you find it's a T1 rectal cancer. It's a smallish lesion, 3 centimeter or so. So you can do an TEO procedure. This is some recorded from someone. You can do it laparoscopy or robotic. But this is only for the crowd. So you find a lesion there. But to find a lesion like this, a small lesion, initially we used to do something like 10 of these cases a year. But after COVID, I think we rarely find any lesion like this. So what you do is just do local excision, excise it completely, go to the fat, and then you stitch it up. So nothing much. Then because of the narrowness of the space, it's difficult. We have the Storz TEO system. You can use the gel port. You can use a robotic system as well. So nothing great. So the operation itself is okay. The suturing becomes a difficult part. You can leave it open or you can close it. Infective complications may be slightly easier. So you need to have a lot of experience with this if you're going to do it at a high volume, and especially with the new studies coming in. The problem is after you've done this operation and the result comes back, and it comes back as T1, but comes back as signet, or it comes as lymphovascular invasion. So these are high-risk groups. So you will require a second surgery for them or adjuvant therapy. So we don't know much about this and how many patients are going to agree for it. So almost 40% of the patients after you finish this excision, they will have some other risk factors and which require second surgery. So after this, you can just close it up, and the procedure itself is okay. The decision later on is more difficult. So once you've done the surgery, they find some high-risk patient. You tell the patient you require a TME or chemoradiation. Adjuvant chemoradiation, actually, recurrence rates are high, 15% or so. There are 15 pooled studies there, but they included positive margin as well. So if you look only at high-risk features without positive margin, the recurrence is 6%. So the other option, if you have a T2 cancer, is something like if you want to do an intersphincteric resection. This is an extended intersphincteric resection, but the dissection is you go down to the pelvic floor. For T2, you have not given radiation. This is the one after radiation. I don't have a shorter clip than this. So you can dissect down to the pelvic floor, dissect in the intersphincteric space, and then you get the colon out and do a hand-sewn anastomosis. So sometimes if you have an early rectal cancer T2, it looks like this is an excessive procedure because you're going to excise the rectum and you can have all the things. He's going to have a stoma, and the stoma may not be reversed because of stenosis and things like that. He can have an LAR syndrome or urinary and sexual function. But you have to look at the patient. If a 30-year-old woman comes to you with T2 rectal cancer, would you give the patient radiotherapy or chemotherapy? They have a good anal tone and they recover quite well. So if you have a T2 rectal cancer in a young female, I would say, okay, do an upfront ISR. They have to be counseled upon, they are going to have all the symptoms, but they get better with time with rehabilitation. But it's the patient who's going to make the decision. Your job is only to offer choices to them. So the other option to this intersphincteric resection is if people who want to avoid stoma is, I will skip all this. You can do the same thing in robotic as well. We'll skip that as well. This one is a Turnbull cutate procedure where you do the same procedure like an intersphincteric resection, but you can leave the colon out for 8 days. You don't need a stoma. You can put a stoma bag in the perineum, and then on day 8 you can suture it without a stoma. And there are good trials done on it. So we have done about 40 or so. In Indian patients, anal tone is slightly higher, so sometimes they get congested. But most important thing is, I think there's a great push for organ preservation for locally advanced thing or opportunistic thing. But people are planning and looking at organ preservation to avoid all these things. We have to realize that surgeons we publish are our complications. You'll talk about leaks, LAR syndrome, urinary and sexual function. You never see any complications of radiotherapy or chemotherapy, okay? It happens. People receive radiotherapy and they die, they have chemotherapy and they die. But that is not that done. So you have to be careful. So now selection is important. So now if you look at TESSAR trial, so now you do a local excision, it comes as T1 or high-risk features. We don't know whether to do TME or chemoradiation. So TESSAR trial will show about it. We'll finally decide what to do. So for case capsule, I'll just show. Suppose this is a 65-year-old gentleman. He has an anterior tumor and someone does an ESD and you've done a complete excision and it comes as positive margin. So if you want to do a TME in this case, you can't because the prostate is there. So you end up giving adjuvant radiation and he has got a high-risk thing. Second case is sometimes someone does a local excision, requires a stoma, and again high-risk features. You give them chemoradiation because they don't want a tumor thing, and then they come back with recurrence again. There are lots of trials thinking about organ preservation coming up there. But when they talk about organ preservation after local excision, you have to see, are they going to comply with the next treatment? So you can see all these studies going there, like cards, only 50% will go for TME. So in fact, if you look at systematic reviews from all the US national database, the incidence of local recurrence in T1 is actually 11%, so it is quite high. If you have to do a salvage procedure after all these studies, APR is high. So you have to tell them, you can do organ preservation, give chemoradiation in due temps, but if you have any high-risk features, there is a high chance that you may end with APR. Complications are there for local excision. Cards actually didn't show there was any difference in LARS between local excision TME sort of group. Star Trek is showing almost 80% can have organ preservation, even short course as well. So most important, you have to remember, morbidity of TEMS is low compared to TME, but local recurrence can be high. You have to be skilled in TME. We don't have high TEU programs. All the trials are done by centers who have a lot of experience in TEU. If you don't have the experience and you offer it, you have to do load things. Salvage surgery can be refused with there and outcomes will there. Her first aim is to improve outcome and survival. If they have salvage surgery, they will require APR. And you have to be careful with this Norwegian thing. Sometimes we get very finicky that we want to do organ preservation, 60%, 80%, and you forget the patient. And some of these patients will never come back to you and they will have a higher recurrence and salvage rate. So be careful. So you can offer standard surgery, you can offer organ preservation, but it is best offered in high volume centers which have experience in TEO. Ongoing trials, Star Trek has got a 1-year follow-up, which looks encouraging, but it is better, careful MDT decision and patient counseling is important. And you involve the patient in the decision and see what they want, and that is more or less. But unless you have an experience, offering this as a standard of care may not be the right thing. Thank you.
Thank you, sir, for your insightful lecture. Now I call upon Dr. Reena, Professor,
They want to ask one question. He's an IAS officer. Combined question.
Yes, sir. I think now on the perspective of organ preservation and avoidance of surgery, the moment low rectal cancer is T3 or T4 plus, we are going to have wait and watch protocol. The moment it is early cancer, T1A, you can have local excision. So what happens? Can you? That means I think that when patient is having T2, you are forcing surgery, and we are not. That is something is overkill. So what is your opinion, sir?
No, I think you have to tell them very clearly what is it. So suppose you are talking about low rectal cancer. So if you do a T2 full thickness excision, the next level is actually the levator. So if you get a clear margin, it comes as T1 and low risk thing, you are done. But 50% of the times, if it comes as T2 margin positive, EMV or any of high risk features, then they require some other therapy, and which is normally a TME, but it will require an APR because the levator is almost exposed. Adjuvant chemoradiation at present has not come, only the TESSAR trial will show. So you have to tell them, I can do local excision for you, but if you require a second surgery, then it will be a permanent stoma.
The
He can
whole
make a
thing is about discussion in the MDT. The last slide was the most important slide. Let us listen to Reena, because Reena wants to finish her talk and then have a discussion with both of us. Right.
Yeah, that makes, I'm so happy to be here, and I'm a radiation oncologist, so I will be giving the perspective only on T1 high risk or T2 N0s. So, and I'll be mostly talking about organ preservation. You all know the perils of APR or undergoing LAR, and if surgery can be avoided. Major loss happens more and more if you combine radiation with low anterior resection. So like if you have local excision, wait and watch versus LAR, you expect higher. This concept of organ preservation in early rectal cancer actually was said by a surgeon in 1930, where he noticed that there was, if you give radium, and local excision without making a permanent stoma, you can achieve organ preservation. But organ preservation now, as Avnish has shared, for early rectal tumors, it is now between 60 to 97%. And otherwise, the larger tumors, it is like 15 to 20%. And local excision followed by, preceded by chemo radiation has been there, very early studies in 2012. And they showed that after radiation, if you do a local excision versus TME, the outcomes are the same. Local recurrence rate, distant mets, everything is same. Again, GRECA2 also showed the same. And you can have organ preservation in 60 to 65% of the patients. Similarly, meta-analysis also says, so for T2 tumors, if you do local excision without neoadjuvant treatment, then the oncological outcomes are poorer. So definitely, if you do local excision, it should be chemoradiation followed by local excision. And this study, again, TREC, they compared organ preservation in short course with local excision versus TME. Again, we see that the organ preservation rate was achieved in 30% of the patients, and quality of life was superior in organ preservation group, where they underwent short course RT followed by excision. And this led to, again, these two trials from Danish trial, where they used long course radiation followed by excision versus short course radiation. They have followed by excision. Long course with TEM achieves a higher preservation rate compared to short course with TEM. So 50% versus 30%. If you just, but trial, I think the characteristics were different. Last week, this trial was presented in ISTRO, and this is the phase 3 trial where they compared long course RT with capecitabine versus short course RT alone, and they also had the third group where the patient preferred surgery upfront, because these were all T2 and early T3 and patients, and they followed the wait and watch protocol, and see majority, 70% were T2 tumors, and you see the TME-free survival was much superior in the long course arm versus short course arm, 80% versus 61%. But when they looked at the small tumors, when they were less than 3 centimeter, whether you give short course or long course, it didn't make a difference. So when you have bigger tumors, definitely long course chemoradiation wins over the short course radiation. And for organ preservation. And of course, you know the advantages and disadvantages. Majority of patients do achieve organ preservation, but the losers, they feel defeated, and proper counseling needs to be done. So without excision, can we do wait and watch? Was floated by Dr. Habergama from Brazil. And now we have huge databases, international databases, more than 2,000 patients now, where they are doing organ preservation for these good responders. Distant metastasis is low, and it has become a norm now. And how do we increase this complete response rate? By increasing the interval, by adding more chemotherapy, by increasing the doses of RT. This was for the locally advanced tumors. Everybody is familiar with OPRA, where you start with the radiation and followed by chemotherapy. TNT approach gives you higher higher rate of organ preservation. These are in locally advanced, not the early. And Dr. Habergama published a specific retrospective study where she observed that if you give chemoradiation alone versus chemoradiation followed by 6 cycles of 5FU for these T2N0s, so there was the organ preservation rate was higher, 67% versus 30%. So chemoradiation, when followed, TNT for these early T2N0s is becoming the new standard of care for organ preservation. There are various ways of escalating radiation doses by EBRT with contact X-ray boost, high dose rate boost, and this OPERA trial is a very elegant trial where T2 and early T3 tumors, they compared contact X-rays with external beam radiation boost. Again, the organ preservation rate, if you look at the whole cohort, was 80% when you give contact X-ray brachytherapy boost versus 59%. And if the tumors are less than 3 centimeter, the organ preservation rate shoots up to 97% versus 63% when you give NACTRT followed by brachytherapy. So these are the various studies which it is a cost-effective approach and quality of life. But the most important is the patient's decision. Patients should be a part of the strategy, a part of discussion from day one when they present to the OPD. This is a very nice, again, study by the Dutch group where they have compared the patient preferences with the healthcare providers, doctors' preferences. We often feel that we are the ones who will decide for them. We are the ones who will give them a correct perspective, but we are highly mistaken. And it is look at this, the patients, when healthcare providers are very much bothered about tumor recurrence and complications, but patients are not bothered. They are, in this study, comes out that patients are willing to sacrifice the oncological outcomes to maintain their daily activities and gain a better prospect of quality of life. So it is not what we think is so important, it is what the patient thinks. So please discuss with the patient their psychological aspect. This is a very good book, very interesting book written by an organ preservation survivor called Mark Davies. It is available online, and it is like how patients think, and it is so important to them. To summarize, if we give short course RT alone with or without TEM, it is also a good option for very elderly patient not fit for any chemo or surgery. You can just give them short course RT. If they have a good response, do an excision. But if you give long course RT and TEM, then 60 to 65% organ preservation rate. If you give these brachytherapy boost, it goes up to the 97%. And so it goes on and on. And it should become a norm rather than exception, watch and wait. And it should be appropriate case selection. MDT approach is a must. Organ preservation is 60 to 97%. And it is the low-lying rectal cancer, early rectal cancer, less than 8 centimeter from anal verge is the new anal cancer. Thank you. And we have a registry run by Shiv Kumar Gudi from our center. And all of you, if you have a watch and wait patients, please enter into this registry. So we will have an Indian registry as well as an Asian registry, because single centers to do this, it looks difficult. So please put your patients in this study. Thank you so much.
Thank you, Dr. Reena. Are there any queries to be asked to her? Yes.
So let's talk only of TEM, not TME. T1 rectal TEM. Hardly any requirement of stoma. Dr. Saklani is here.
Yeah, so I'm only talking about high-risk T1 or T2's majority.
No,
I'm not talking of T1s.
My point is that assuming that if you are able to achieve TEM, stoma requirement is much less. The recurrence rate is 7%. In an organ preservation, the recurrence rate is 7 to 8%. And you talked about the patient preference. So I wanted to ask you, in your experience, if you tell a young patient that the stoma will not be required, and your oncological outcome, either this side or this side, ranges around 7%, what would patients select? Majority of the patient who want to go for wait and watch mainly are for two reasons. One is stoma, one is sexual dysfunction. If both are not compromised, do you think that patient will compromise oncological outcome? Just a question.
So we don't have an Indian perspective, but here in the many of the quality of life patients' perspective, they are willing to compromise also, because patients think differently than us. You know, we are so bothered about local recurrence, regrowth, again, you know, stoma, this and that. But this is what we oncologists have to understand. And in fact, I was discussing with Shirley that we should have an Indian patient perspective, and we will be floating this kind of study where we will have from different regions and religions. You know, in our society, religion plays a big role. So like we should have our own Indian perspective.
Yeah, we had this talk as surgeon's perspective, radiotherapist perspective. Other concept coming up is the patient perspective. Actually, each patient, they have their own, the thought process differs, because we also have a large data on this wait and watch. We keep discussing about these things with the patient. Each patient has his own, and as you pointed out, 30 years, 60 years, it's a huge difference between these two age patterns. So ultimately it ends up with talking to the patient, finding out what that individual wants, and then go about the whole treatment. As you say, some of the patient will want only organ preservation. Most of them, if you first give the option of an organ preservation, they will ask for organ preservation. That's the way it goes.
No, Amish, you have to see the patients that we have in the country are younger. Okay, it's not 60, 65 where all the trials are done. So if some 33-year-old girl comes to you and organ preservation, you're going to irradiate her ovaries and the vagina, so sexual function is affected. And when you talk about wait and watch versus local excision, all the previous trials did a lot of TEMS, whatever, the CARDS, the TREC study, they were doing local excision. But if you do salvage surgery for local excision, then the complications of local excision per TME are always on the higher side. So now in all the current studies, what Rina says, if you give a therapy, the first you do wait and watch. Okay. If it wait and watch, there is still local, then you can do local excision and then salvage surgery. So organ preservation, you have to look at perspectives.
I agree. He wanted the T1, so we would offer local excision as well. We will give all the options to the patient.
No, Reena, my point was about everybody's talking about the patient preference. So I'll give you one example, sir, that like Dr. Saklani said, Indians are slightly different.
Hello.
You know the prostate cancer, intermediate high risk, observation versus surgery versus RT, 15 years of follow-up. I had done the survey of 200 oncologists in India. Not a single one opted for observation. Not a single one. They all said cure rate is much more, and at the age of 50, if you do a radical prostatectomy and you get a complete cure in this early stage, intermediate, low risk prostate cancer, we would go for surgery. So my point is, how we are looking at the patient preference also is important. Oncology, yes. If oncology is convinced about the organ preservation, probably our tone would be different to the patient versus if we are not convinced.
Yeah, very true.
Yes, so we do, first we have to start practicing this approach. We become more confident. Like in TMH, like we are doing this since 2013 now, 12 years. So we can give a better perspective to the patient.
Yeah,
yes. But then patient ultimately takes their own decision. Even after the regrowth, they decide not to get operated. We can't help it.
You need to believe the treatment what you are giving. Then the whole thing will come from your mouth, or else you will be very hesitant. Yes. That applies to almost all sites, not only on the rectum. It applies to almost all the sites. Thank you, Dr. Reena.
Thank you, ma'am, for sharing your knowledge with us.